and literature, it ranges from 0.47 to 4.14. So what does it mean actually? A lower alpha by beta ratio basically means that if we use a larger fraction size, then it is going to kill the tumor cells more as compared to the normal tissue cells for the same isoeffective normal tissue toxicity. So that is the main reason why it is being thought that if we use larger fraction size, and especially in cases of prostate, then it would benefit the patients more. Apart from that, SBRT is beneficial in terms of patient convenience because the treatment shortens to around 2 weeks rather than the whole 7 or 8 weeks. Furthermore, by increasing the turnover on the machines, we can treat more number of patients. Apart from that, if we take into consideration the logistics and the ancillary costs of the treatment, the prolonged radiotherapy treatment, then probably the cost of SBRT would come to be less than the conventional radiotherapy treatment. Apart from that, these days with better technology, better treatment delivery available, and our confidence in treating and delivering the radiotherapy treatment has increased due to the use of IGRT. So we can deliver SBRT with more confidence to the patients and benefit them. Now, coming to the use of SBRT in especially low and intermediate risk patients. So there are various retrospective data and a few phase 1, phase 2 studies are available, and a systematic review of literature consisting of around 21 to 22 studies are available in the literature. But this is the study, the prostate advances in the comparative evidence, the PACE studies. These are comparing the use of SBRT versus the conventional radiotherapy in a phase 3 trial setting. So basically, what PACE does is that they basically take localized prostate cancer patients, and if they are low or intermediate risk, then they are considered for surgery. If they are eligible for surgery, then they are randomized into either SBRT or surgery, and they go to the PACE-A study, which has the quality of life and the EPIC quality of life scores at 2 years as the primary endpoint. Subsequently, if surgery is not being considered, then these patients are randomized into either conventional radiotherapy or SBRT, which has taken around 874 patients in the phase 3 setting, and the clinical or biochemical failure at 5 years as the primary endpoint. So in the conventional RT setting, they are using either conventional RT of 78 gray or moderate hypofractionation of around 62 gray in 20 fractions, and SBRT of 36.25 gray in 5 fractions to the PTV. The important thing to note in this PACE-A and PACE-B is that anti-androgen therapy or ADT is not being used in these patients. Now coming to the PACE-A results, which compares the surgery versus the SBRT in lower intermediate risk patients who are eligible for surgery. So in this, as we can see, surgery does poorly in terms of urinary incontinence and sexual functions, but surgery has a better bowel score than SBRT as per the quality of life results. Now coming to the PACE-B, if the 5-year results of PACE-B had shown that the conventional radiotherapy and SBRT has no difference as per the outcome after 5 years. And this same PACE-B, the acute toxicity, as we can see also, is a bit more with the SBRT if we can see, but all of these are statistically insignificant. Now, when this five-year results were reported last year in Astro 2023, they reported the worst GU toxicity of this treatment, conventional radiotherapy versus SBRT. And as we can see, there is a slightly more grade 2 toxicity of 8.5% with SBRT, but this is not statistically significant. Now, coming to the SBRT in high-risk patients. So, this is the first randomized controlled trial, non-inferiority design, published pertaining to these patients. Basically, this trial included patients of intermediate risk and high risk. Only 11% patients were of high risk. They used a ultra-hypofractionated treatment of around 42.7 gray in 7 fractions, alternate day treatment, versus conventional fractionated treatment of around 78 gray in 39 fractions, which included 1,200 patients. And the primary endpoint was failure-free survival at 5 years. So as we can see, the failure-free survival at 5 years in both the arms, conventional fractionated RT and SBRT, was the same at 84%. Even the overall survival at 5 years was very good, 96% with conventional fractionated RT and 94% with ultra-hypofractionated RT or SBRT. Now coming to the toxicity. As we can see from this graph, the urinary related toxicity, they are a bit increased in the SBRT arm and they come down subsequently. But at around 1 year, they increase a bit. But all of these in urinary, these are statistically non-significant. Even the bowel score, the acute event, it increases a bit. But after a few months or around 3 months, they all come down to the baseline or the same level. Similarly, erectile dysfunction also. This is the arms are quite similar, but the gradual increase in the erectile dysfunction, as we can see, this is basically due to the use of EDT in this trial, which has been used for around 1.5 years. So what could be the possible reasons of this increase in the acute toxicity with SBRT or all in this trial particularly? Because as per this trial, there was a margin taken around the prostate was around 7 mm. And moreover, 80% of patients were treated with 3T CRT, not the current standard of care advanced ARC or IMRT techniques. Now, in all high-risk patients, there is a dilemma of whether to give pelvic radiotherapy or elective nodal irradiation or not. Recently, this POP-RT study has come up, which has kind of cleared this doubt to some extent, but still it remains while we are using SBRT treatment per se. So the first data for this came from India only. One of the biggest data, retrospective data of prospectively maintained database, which included audit of 68 patients. Among them, 54% of patients were node positive, and the treatment modality was prostate along with the gross node was given to up to 35 to 37.5 gray in 5 fractions. And the whole of the pelvis should have been treated to 25 gray in 5 fractions. And this pelvic elective nodal irradiation was done in around 50% of patients who had either initial gross nodes or subsequently presence of nodes after the use of EDT also. So at the median follow-up of relatively short 18 months, 97% of patients were alive and 94% of patients were biochemically controlled. When we come to the toxicity data, we can see that there is minuscule number of late genitourinary toxicity at grade 3. Only 2 patients had suffered this grade 3 GU toxicity, and the other toxicity are relatively tolerable and are manageable at grade 2 only. So from this study, it was pretty clear that in a real world setting also, SBRT along with the pelvic radiotherapy treatment is tolerable and is doable in patients who require pelvic radiotherapy. Apart from this, the first trial, the first phase 1, phase 2 trial called the Saturn trial, which included 30 patients, came to the picture in 2018. And the treatment protocol of this trial was 25 gray to the pelvis, along with 40 gray to the prostate with SIB in a weekly fractionation schedule, and ADT of around 18 months. And as we can see, the toxicity results, the grade 2 toxicity results, the grade 2 GU toxicity was around 46%, and late GU toxicity was around 52%. Coming to the GI toxicity, which were very limited in number at around 3.3%, and late GI toxicity, the patient complained of around 32% of toxicity. But the point to note is that no grade 3 toxicity was seen in this Saturn trial. So as we can see from this, the initial drop in the toxicity score of the EPIC score is first seen just after the radiotherapy is complete, and it gradually improves to the baseline level subsequently in all the parameters of the urinary tract, the bowel parameters, even the sexual and the hormonal. So the authors concluded that incorporating pelvic radiation for high-risk prostate cancer within combination with androgen deprivation therapy is feasible in these high-risk patients and is well tolerated. Now, coming to the PRIME trial, which included the patients of localized prostate cancer or having pelvic lymph nodes. PSMA PET CT, all patients were staged as per the PSMA PET CT, and the patients had the ADT for around 2 years or had orchidectomy. The radiotherapy in the moderate hypofractionation arm was 68 Gray in 25 fractions and SBRT of 36.2 Gray in 5 fractions, along with, if there was gross node, then the 60 Gray in 25 fraction in the moderate hypofractionation arm and 30 Gray in 5 fraction in the extreme hypofractionation arm, along with the prophylactic nodal irradiation to the pelvis. So last year in Astro, the proposed interim or the planned interim results of this study was published, which included 296 patients. And as we can see, there is a very minimal number of grade 3 toxicity. The urinary grade 3 toxicity was seen in only 3 patients out of 296 patients. And the gastrointestinal grade 3 toxicity was seen in only 2 patients. So this extreme hypofractionation with the SIB boost to the gross node if present, and also the pelvic elective nodal irradiation is feasible, doable, and is well tolerated for the patients. So we are actively waiting for this results of the survival results of this data, this PRIME trial. Now, there is another dilemma while choosing the patients for SBRT, whether we should take into consideration the IPSS score or not. So here are 2 papers. I'll go to one by one. They are retrospective audits only. But this paper by Gorovets et al., which included 72 patients, we can see that after the SBRT also, the IPSS score has improved after SBRT in all the parameters, as we can see. If in some parameters, if at all it has not improved, then also it has stabilized, at least not worsened. So we can safely say that if in poor IPSS score patients, they included patients of IPSS score more than 15. So they also, in them also, we can safely use SBRT because it is not going to worsen the symptoms. Similarly, in this study by Agham et al., which included also 72 patients, we can see that overall IPSS score in all the patients, they gradually came on decreasing, and there was gradual improvement in the IPSS score of these patients after SBRT as well. Now, coming to our institutional protocol. So here we try SBRT, or we consider SBRT for patients up to stage 3B, primary T3B, we may consider. The patient, we don't take node positive patients as yet. We consider them in node negative patients, mostly staged with PSMA PET. We look for that, and also an MP-MRI for these patients is also essential, either for diagnostic purpose or at least we need them for planning purposes. We look for them. The PSA usually we take is less than 50 nanogram per ml, And ADT, we use combinedly with ADT as per the risk stratification of the patients. And we do not use elective nodal irradiation or pelvic irradiation as of now in SBRT patients as in our institute. So outside trial, we are running a few trials in this patient population also. So outside trial setting, we have collected the data of around 24 patients, and all of them have completed at least 6 months of follow-up as of now. So the toxicity data are available with us as of now. So the median age of the patient is around 68.5 years. The volume of prostate, we treat relatively larger prostate sizes at around 40 cc. The median PSA or the mean PSA at our center is the patients we have treated is around 27, and the Gleason score is 7. We have a follow-up of around 17 months as of now, median follow-up of 17 months. And we have treated out of these 24 patients, 66% are high-risk patients. There has been a clinical biochemical failure in only one patient out of this 24, and that is after 31 months of diagnosis. And a median follow-up, as we have discussed, the median follow-up is around 17 months. The toxicity, we have not encountered any grade 3 toxicity. The most notable toxicity we have found is that one patient has got grade 2 late GI toxicity as of now. And a few of the patients have GI late GU toxicity as grade 1 as well. So after all this discussion, recently this NCCN guideline in 2023 has incorporated SBRT treatment into very all the risk categories from starting from very low to high and very high risk categories, except regional lymph node positivity. Even NCCN guidelines recommends consideration of SBRT of 6 gray in 6 fractions that was given weekly in Stampede trial as one of the treatment modalities in low volume M1 disease as well. So in those patients also, the SBRT treatment of primary prostate can be an option. So with this, I conclude. Thanks a lot for patient hearing.
Dr. Venkal, any questions from the audience? So I'll ask one question.
Sure, sir.
The eternal debate, intermediate, high intermediate risk, localized disease, SBRT or surgery?
So, SBRT.
Finished doing a meta-analysis in this group of patients, including low and intermediate risk of patients. And we have found no difference. It is under review in European Urology Journal. Hopefully, we get published. Dr. Shashank is also part of this meta-analysis. So there has been no difference in terms of survival, in terms of biochemical recurrence-free survival. The only difference was on the toxicity pattern. Like radiation had more bowel function problems, and surgery had incontinence problems. So that was the only difference. It should be patient's choice probably in this group of patients.
Yes, definitely. This option.
Depends on the patient, sir. If the patient is ready for diaper use versus patient having to, come out of social functions because of bowel problems, you probably take surgery as the choice. But if patient bowel function is the problem, then I mean, he's okay with the bowel.
Actually,
and reversibility of the so all the data that we collected was having at least a 5-year follow-up. So we had taken data only from RTT, which were completed and had a 5-year follow-up. So I think it's quite mature data. What percentage were the toxicity reversible in either? I wouldn't be able to comment on that, sir. Yes. Like robotic surgery and better understanding of the anatomy and even the laparoscopic prostatectomy, because robotic is essentially the laparoscopy. machine which helps the surgeon to do the laparoscopy. So the return of early continence is far better in robotic procedures, and the overall continence rate after 1 year is somewhere around 80%, in the range of 80%. So patients are continent at the end of 1 year. 80% is 0 to 1 pad. You basically 1 pad per day. So if we consider it 2 pads, 3 pads per day, then it goes to 90 to 90%. As far as the continence is concerned. Right. So after radical prostatectomy, obviously results are better with the robotic or minimal invasive techniques. Urinary incontinence just after the catheter removal, urinary continence, it's around 10 to 30%. As the time of the follow-up increases, at 3 months, it's around 50%. And at the 1 year follow-up, it's around 80% or even more than 90% if nerve sparing techniques is performed. So urinary incontinence after radical prostatectomy is transient or temporary in most of the cases. Permanent urinary incontinence happens in around 10 to 20%.
So actually, this toxicity, the GI, the GI toxicity which we are talking about in these patients, they are actually not bothersome for the patient. We are talking of around grade 1 and grade 2 toxicity. Grade 3 toxicity are not seen as such. And those grade 2 toxicity, they are mostly related to the rectal bleeding and some kind of bowel discomfort, as the patient say it. But it's not kind of bothersome for the patient as such. It doesn't affect the quality of life directly for the patient. And the proctitis, which grade 2 proctitis, can be taken care of conservatively as well. So finally, in my opinion, it boils down to the choice of the patient. The patient should be given the options and properly should be counseled about the possible side effects and the pros and cons of this modality. Because as per the data, both the modalities are good enough to take care of these patients.
Right. The problem with just analyzing data and analysis is it doesn't include surgical expertise. It doesn't other factors like there is a homogeneous scoring that was used for bowel function. Some of them use one from the other similar for movement. So obviously data seems to be similar, but obviously surgical expertise being better, probably being concentrated even lower than. Thank you, Dr. Prashant. I would like to thank my co-chairperson also. To the organizers, we have managed to include one more debate talk into the schedule. Thank you.
Thank you.
Thank you, our speakers, for this wonderful insightness. Now I request our chairperson to honor our speakers. I request Dr. Ashutosh sir to honor Dr. Shashikant sir. I request Dr. Lalit sir to honor Dr. Shashank. I request Dr. Lalit sir to honor Dr. Manikandan. I request Dr. Himanshu sir to honor. I request Dr. Neha to honor. Thank you, sir. Thank you, sir. Dr. Neha to honor Dr. Lincoln Pujari. Now I'd like to thank our chairperson to wonderfully facilitate the chair of this session. I request Dr. B.K. Mishra sir to felicitate our chairperson, Dr. Ashutosh Mukherjee. Dr. Lalit Agrawal, sir, please come forward. Dr. Himanshu Pandey, sir. Dr. Neha Singh.